Um, so good morning and welcome to Grand Rounds. Apologies that we were not able to hold Grand Rounds last week. There was a kind of last minute cancellation and we weren't able to fill the spot. So I do apologize for that. And I want to remind everyone that we will have Grand Rounds until the end of June, and then we'll be taking a break as we usually do over the summer months, starting again in September. So enjoy our rounds for today. So I will begin as usual with acknowledging that Ottawa is built on unceded Algonquin and Anishinaabe territory. Peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. I'm delighted to present our speaker for this morning, Dr. Carsten Krueger. For those of you who have not met Carsten, Carsten is an infectious diseases pediatrician who is completing his fellowship in antibiotic stewardship here at CHEO. He received his medical degree from the University of Calgary, completed his pediatric residency at Sick Kids, and finished this off with his infectious diseases fellowship at CHEO. Next year, he will be joining the section of infectious diseases at the Alberta Children's Hospital, and apparently watching his newborn grow up way too fast. So congratulations to you on all of that, Carsten. So buckle up. He is going to be taking us on a fellow's journey, talking about new approaches to antimicrobial stewardship in 2023. Over to you,
Great.
Carsten.
Thanks so much. Let's see. People can see the slide advance, I hope. I don't have any disclosure, but I would be remiss if I didn't start by thanking Dr. Lasso for her excellent mentorship and instruction over the year, and for the Division of Infectious Diseases at large for their mentorship the last 2 years. I guess my one disclosure is that I'm not in favor of any more antibiotic resistance. These are our objectives: to review the principles of traditional approaches of antibiotic stewardship, examine the promises and pitfalls of antimicrobial stewardship in non-traditional settings, highlight the innovative work being done by CHEO's antimicrobial stewardship program to better meet the needs of children and our hospital stakeholders. And to do this, we'll sort of be going through this outline, which we'll revisit as we progress. So since this talk is open to a wide audience, I'll start with some general definitions and describe the problem of antimicrobial resistance and why there's a fellowship even. So antimicrobial stewardship is an activity focusing on the appropriate prescribing of antibiotics for infections, not just shorter, to prevent the emergence of antibiotic-resistant organisms. And some expand on this to say that, optimization of antimicrobials should result in the best clinical outcome for the treatment or prevention of infections with minimal toxicity to the patient, and minimal harm or safety concerns for them. And as you can imagine, this is no small task. So antimicrobial stewardship programs then are tasked with the systematic implementation of interventions aiming to optimize antibiotic use, which includes things like prospective audit and feedback, or stewardship rounds, as they've become known at CHEO, continued education of providers, and updating local treatment guidelines. The problem that stewardship programs aim to address are many but related, and pose challenges for individual patients as well as healthcare systems. Recent estimates put the global number of deaths annually attributable to antimicrobial resistance at 1.27 million every year. Antibiotics are a leading cause of emergency visits due to adverse drug reactions among children and adolescents. And we also know that antibiotic use varies significantly between American children's hospitals, even after you adjust for patient level and hospital level demographics and clinical characteristics. both in terms of the percent of children who are on antibiotics, but then also the number of antibiotics days normalized per 1,000 patient days, which is a common stewardship metric, which will come up later. And then finally, inappropriate antibiotic use is quite costly, both in terms of the pure cost of antimicrobial as in acquisition, purchasing, but then also for those who are admitted, the bundle of care that's needed to provide for those patients. So an American study found that inappropriate antibiotic prescribing for otitis media, group A strep pharyngitis, and sinusitis accounted for $65.7 million of potentially avoidable healthcare expenditures nationally, like every year, or at least in the year that it was studied. While antibiotics have been an unparalleled development in the treatment of infectious diseases, their indiscriminate use can have consequences for children's health and safety. As you know, they've been associated with C. diff diarrhea and atopic disease, but also with obesity, autoimmune diseases like IBD and celiac diseases, among emerging reports of other conditions. Also, receipt of antibiotics for acute respiratory illnesses, or viruses, sinusitis, seems to be associated with an increased likelihood in caregivers in seeking antibiotics, like antibiotic-seeking behaviors, and subsequent receipt of antibiotics from clinicians, which can create a vicious cycle. You know, if you believe it's working for your virus, then you'll be inclined to try to get it for the next episode. So how do stewardship programs figure into these problems? Well, it's believed that antimicrobial stewardship programs reduce antibiotic use, and that contributes to reducing or halting antimicrobial resistance, though this has been admittedly difficult to prove. What we can prove is that stewardship programs improve guideline-concordant care. They're able to improve patient outcomes like mortality, improve clinical cure rate, and reduce treatment failures. They can also result in significant cost savings, and the figures vary by the size of the hospital, but you can see some here at a couple of larger centers, and that's annually $200,000 to $900,000 in the States, that is. And families are also concerned about antimicrobial resistance. In a Canadian study conducted by the Pediatric Emergency Research Canada Network, they identified antimicrobial stewardship as a family research priority. And of course, if for no other reason, antibiotic stewardship is a required organizational practice of Accreditation Canada. So how did the concept of stewardship and antimicrobial stewardship programs, or ASPs, arise? Stewardship as a concept has been around since ancient times, with the core tenet being the responsibility to look after something of a value and to be accountable for its well-being. The need for antimicrobial stewardship was foreseen by none other than those credited with the discovery of antibiotics. And you can see here their warning for those who made use of their discoveries after they passed. However, the term antibiotic stewardship wasn't coined until over 50 years later. And in the intervening time, as supplies of antibiotics became more secure, durations of therapies increased, and priorities shifted from ensuring patient survival to eradicating bacteria and preventing relapses. And in '97, the IDSA, Infectious Diseases Society of America, published a position statement for the prevention and reduction of antimicrobial resistance, which referenced antibiotic stewardship programs. Early models of ASPs were heterogeneous, were led, either by an ID physician or a pharmacist, and variably focused on things like IV to oral conversions, education, and development of care pathways. The IDSA later refined their position statement in 2007 and provided more guidance on implementing antibiotic stewardship programs. And this informed what came next, which I really think was a game changer for my field, which is the current model of ASP as informed by the CDC's core elements, which was published in 2014. These elements highlighted the need for leadership buy-in, accountability of the program, and pharmacy expertise as the basic human resource requirements of the stewardship programs. And their function was defined by these principles to track antimicrobial use and relative outcomes, intervene to optimize use, that's important, and report on our findings and activity, as well as to educate those around us on antibiotic use. Today, most antibiotic stewardship programs will have at their core one of these two approaches. Handshake stewardship on the left, coined by Colorado Children's in 2013, takes a more permissive approach, wherein nearly all antibiotics can be prescribed by clinicians, however they like, but the stewardship program will review their prescribing and discusses with them ways to optimize use with the attending team. This approach is emphasizes education and is quite labor intensive and does require long-term and sustained involvement to maintain improvements that were made. This is our approach at CHEO, which we've been using, or Dr. Lusso has been using together with Dr. Thampi and Dr. Sampson since before handshake stewardship was coined. On the right, formulary restriction is when certain broad spectrum antibiotics require ID or pharmacy approval to start or continue. Little attention or comparatively little attention is paid to education, and as a result, programs tend to be less, need less resources. But as a result, prescribers improving their practice is less likely, and sometimes people can game the system to circumvent the approval process. And you still need long-term investment to maintain improvements. So coming back to the CDC core elements and their impact, after their implementation in 2014, antibiotic stewardship programs in the states became more uniform in their structure and activities, and more adopted a co-led model. But most continued to focus really on traditional inpatient groups like medical wards, intensive care, and general surgery. But some pioneers have worked to expand antimicrobial stewardship into non-traditional settings like immunocompromised patients and the emergency department, and newly telestewardship, which I'll talk about now. So one novel area of stewardship is telestewardship, which involves antibiotic stewardship program personnel providing services to often an external institution, usually from a distance. But with this, there are challenges. As one can imagine, it would be difficult to build trusting relationships with prescribers who you've never met before over Zoom, especially when you may be perceived as criticizing their antibiotic use from an ivory tower. Secondly, the external site may not have the same EMR as you do at your host site. And so stewardship programs or stewards are unable to verify what they're being told, which can affect the confidence we have giving recommendations, which would lead to longer or broader treatments. Remuneration for stewardship services provided to external sites may be difficult to arrange due to the silos we traditionally operate in institutionally, while the problem of antimicrobial resistance crosses institutional barriers, and improving antimicrobial use in our broader community would benefit our patients. But there just isn't a setup for that. And lastly, telestewards are outsiders to the culture of practice at institutions they remotely serve. And as a result, they may be unaware of local factors that may pose barriers to optimizing antibiotic use. Telestewardship programs have actually demonstrated or been demonstrated to confer all the benefits of general antibiotic stewardship programs in terms of improving antimicrobial use, cost avoidance, as well as improving guideline concordant care and patient mortality. Telesteward recipients usually feel that the modality adequately allows them to communicate the nuances of their patient cases. And then similar to in-person stewardship, early career and female physicians tend to be more receptive to stewardship program input and collaborative, but stop and narrow suggestions continue to be a hard sell for all really involved. And implementation frameworks have been developed to help guide stewardship programs that are new to the telestewardship space. So shifting gears a little bit to antimicrobial stewardship in immunocompromised children. This is a challenging area for several reasons. Patients are usually highly complex and often require discussion around patient level or patient-specific factors, in addition to the general principles that we try to adhere to for general antibiotic stewardship. And I guess comparatively little, has been, evidence of safety and efficacy of stewardship programs exists in the literature. These children also have subtle signs and symptoms of infections, and they can often have atypical presentations and unusual organisms. As true for all of pediatrics, the barrier to collecting invasive specimens may be higher than in immunocompromised adults, where a lot of the literature is based, and investigations may have lower yield. And lastly, due to the high mortality related to invasive bacterial and fungal and viral infections, attending teams may have a lower, understandably lower tolerance for risk and uncertainty. So what little evidence exists for antimicrobial stewardship programs in immunocompromised patients predominantly is in the solid organ and bone marrow transplant settings. Yet only 50% of American pediatric transplant centers with stewardship programs actually serve transplant patients with their program. For what's been reported, prospective audit and feedback or stewardship rounds, as you'll remember, remains a staple for these patients, with conceptual models having been developed to highlight the importance of transplant team and multidisciplinary buy-in. Targets include durations of antibiotic therapy for febrile neutropenic patients after the fever is resolved, curtailing empiric vancomycin addition for stable but persistently febrile neutropenic children. And other efforts have focused on stewardship programs co-developing local guidelines with transplant teams to help standardize care and reduce inappropriate antimicrobial prophylaxis around low-risk patients. And then delabeling penicillin allergies, which we'll touch on later, has been deemed a low-risk and promising strategy, as avoidance of beta-lactams is associated with increased use of inappropriate empiric therapies like fluoroquinolones and vancomycin. Another sort of strategy that's been proposed is transplant-specific antibiograms, which have been explored and can help inform empiric therapies, but may be limited by the number of isolates and the number of transplant patients seen at the center. Antifungal stewardship is another important and emerging area for these patients, And because this category of medication is quite expensive for hospitals, optimizing their use, even though there's not as many of them used, can be quite cost saving. And then there's several ways of doing this, which you can see on the left, but I won't go over. Development of metrics specific to immunocompromised patients has been an important area of research, and some have been suggested, but to date it's unclear about what, or there isn't sort of a well-established transplant-specific metric for antibiotic stewardship. So today we're stuck with the familiar metrics you see here, like rates of C. diff, antimicrobial cost and utilization, and then the outcomes of antibiotic stewardship rounds. So moving again into another area of antibiotic stewardship is in the ambulatory setting. So expanding stewardship programs to include immunocompromised patients is meaningful because those patients are at the highest risk of poor outcomes from antibiotic-resistant organisms and get broad-spectrum therapies. But outpatient and emergency department antibiotic use really is a hidden body of an antibiotic prescribing iceberg. It's estimated that 59 to 90% of all antibiotic prescriptions are given in these settings, and at least 30% of them are believed to be inappropriate. This setting, the outpatient setting, is unique in that the patients are generally less unwell. Guidelines exist to guide durations of therapy for common infections, and patients are seen, and new literature exists to support short durations of therapy, even shorter than sort of our National Canadian Pediatric Society guidelines in some cases. So here, patients are seen in high volumes, and thus the potential for absolute impact on community-level antimicrobial use is high. So, in recognition of this important area, the CDC released a companion core elements specific to the ambulatory setting. So this isn't to say that there aren't any challenges in the outpatient setting. So because stewardship in this program has to be retrospective, we can't be for at once all the time, it relies on both an EMR and the ability to pull data from it. For some centers, this is a non-starter that completely walls off this area of expansion. But if data is available, the next barrier is establishing buy-in from the group you wish to steward. And without buy-in, it's likewise impossible to proceed. As before, metrics and benchmarks are not well defined in this sort of new area. And then one big limitation is the inability to assess if a patient truly met the criteria for the infection that was diagnosed, as lists of patients that are being reviewed typically are generated by ICD-10 code rather than diving into the specific clinical features given the high volume of patients seen. So for instance, in one study at Sick Kids recently, 55% of children diagnosed with UTI in the emergency department failed to grow an organism in culture. And finally, it's been observed that physicians serving the same patient population actually diagnose bacterial infections like sinusitis and otitis media at quite different rates. This kind of gets back to that diagnostic accuracy part. To date, emergency department stewardship programs are a nascent field with few, if any, children's hospitals in Canada longitudinally engaging the emergency department. Addressing antibiotic use in outpatients requires a multi-pronged approach, and disseminating the latest evidence to prescribers is important, but it's not sufficient on its own. Behavioral economics approaches like putting up posters in the hospital saying, that we commit to appropriate antibiotic use has yielded surprisingly good benefits and been quite effective, as has been arming first-line or frontline staff with communication tools aiming to address and patient expectations without caving and prescribing antibiotics. But for resource-limited stewardship programs, simple electronic medical record solutions like making prescribers provide an indication when at the time that they're prescribing the antibiotic, like linking it to the problem, are cost-effective and have been shown to be minimally disruptive. This, along with adjusting suggested duration therapy buttons in EPIC, can help encourage appropriate and short duration prescribing. But at the same time, then you need to have people to help you with making those electronic medical record changes, which can be another problem. One of my favorite approaches that you'll hear about soon is the behavioral economics approach of anonymous peer-to-peer comparison. This approach has been found to be effective in reducing inappropriate antibiotic prescribing, but as you can see on the figure on the left here, the same with all stewardship programs, sustained feedback is needed to maintain the improvements before you regress to the mean. The idea is to highlight model behavior rather than shining a spotlight on suboptimal performance. And the emergency department is, I find, the perfect place for these types of interventions because they're very quality improvement minded place, I must say. And they have their own metrics for return visits and among other things. So integrating antibiotic appropriateness into their existing quality improvement infrastructure can be simple if there's leadership buy-in. So this brings me now to some of the exciting work that I've had the honor of contributing to during my fellowships at CHEO. And I'll start with the emergency department antibiotic prescribing reports, which have been affectionately called antibiotic prescribing report cards, which some of you will be acquainted with. So previously, Nicole and I, together with Dr. Al-Qureshi in the emergency department, looked into the patterns of antibiotic use for community-acquired pneumonia, UTI, and otitis media in children who are over 2 years of age, seen in the emergency department. We found that overall guideline concordance was good, but we did notice that durations were generally very evenly split between the upper and the lower ends of the duration range. So at 7 days or at 10 days for pneumonia, for instance. And indeed, we found through cluster analysis that some providers tended to pretty uniformly prescribe at that longer end of the duration range compared to others which prescribe at the shorter end. But remember, I guess for this study, we had only looked at patients who were being discharged from the emergency department who weren't being admitted. And so they would be believed to be of lower severity of illness. And new evidence would suggest that these patients could be managed with shorter durations of therapy often. So how would we go about trying to improve antibiotic use for these patients? Simply showing data, like through traditional ways like this right here, is unlikely to change an individual's prescribing behavior in and of itself. So we needed a new approach, one that used behavioral science to create lasting change in practice around the management of these infections. And then we also put in cellulitis as well. And together, these 4 infections account for most antibiotic use in the emergency department. So for us, the intervention that we came up with was periodic prescribing reports for those 4 infections. And at first, it was similar to the previous slide, but then I learned about quality improvement figures called Pareto charts, which I'll explain soon for those who aren't familiar. And we decided to incorporate them as a form of anonymous peer-to-peer comparison. So as mentioned, peer-to-peer comparison has been found to be already effective at reducing antibiotic use more broadly. So this is kind of the example of the content of one of these reports. So we launched these after a presentation in their emergency department in early 2021, January 2021, and they were distributed semi-annually thereafter. So, our objective for this now new study was to assess the impact of these prescribing reports on antibiotic use in the emergency department a year after implementation, which was this past January. And these report cards, with these report cards, emergency physicians were given a flower pseudonym so that they could anonymously compare their prescribing with their peers. So the focus of these reports was on the number and proportion of prescriptions that were given with durations longer than what would be minimally recommended by the Canadian Pediatric Society practice points. So for instance, for community-acquired pneumonia, that would be any duration greater than 7 days, or UTI, for instance, the same. So we retrospectively reviewed all prescriptions for children seen in the and discharged in eMERGE since 2021, which was pre-implementation, and then, I guess it was 2022, time flies, which was the post-implementation year, with one of the 4 infections. And we summarized their characteristics descriptively and calculated the absolute reduction in antibiotic days prescribed by calculating the difference between the historically expected antibiotic use and what was actually observed post-intervention. So as alluded to earlier, we used de-identified Pareto charts, like the one you see here, as a way of allowing physicians to compare their practice to their peers. A Pareto chart is used to visualize key contributors to a problem. The clinicians on the left, who are highlighted in red, would be labeled the vital few, who make up 70% of those longer than minimally recommended prescriptions, whereas the people on the right would contribute relatively little. We use the absolute numbers rather than the percentages because we wanted to make the biggest splash on absolute antibiotic use. So there were nearly 5,500 prescriptions that were identified as distributed by disease and in the pre and post implementation quarters or years, as you see here. And then just sort of explain the discrepancy, or not discrepancy, like big difference in community-acquired pneumonia. Remember, emergency department visits or volumes for infections didn't start to pick up to the pre-COVID levels until Q3, Q4 of 2021. Hence why like otitis media and CAP are so different. So overall, we noticed uniformly positive changes in durations of therapy prescribed for each of the 4 infections, which I'll highlight now. So in 2022, the eMERGE reduced the proportion of children receiving 10-day prescriptions for pneumonia by 14% compared to the pre-implementation year. And they also exceeded our expectations, like our target of 7 days. Show us the evidence, like 5 days is good for these patients, we can do that. And we saw a 31% increase in 5-day durations of therapy, which is an emerging standard of care for outpatient pneumonia. In 2022, the eMERGE increased the proportion of children receiving 5-day durations of therapy for otitis media by 13% compared with pre-implementation year, with a concurrent decrease in 10-day durations. And then for urinary tract infection, the eMERGE reduced the proportion of children receiving 10-day prescriptions by 10% compared with the pre-implementation year. We also saw more use of 5-day durations, which were presumably for cystitis, which can be managed with short durations of therapy. And while there's no Canadian guidelines per se, at least from the Canadian Pediatric Society for the treatment of cellulitis, literature and the NICE guidelines support 5-day durations of therapy for most cases of uncomplicated cellulitis, which was our reference point. And in 2022, the eMERGE increased the proportion of children receiving 5-day durations by 16% compared with the pre-implementation quarter. So what was the end result of all these changes? Well, we estimate that thanks to the great work of the emergency department, the children served by CHEO were able to avoid nearly 2,500 days of unnecessary antibiotics, which is a total decrease in antibiotic use for these infections of 12%. If I was to give a day of therapy to my daughter, who's just over a month old now, each day for the duration of all of these days saved, she would be taking antibiotics until she was over 6.5 years old. So it's a tremendous amount of antibiotic consumption that was avoided. So when normalized to per 1,000 infection visits, the change remains clear at a glance and was statistically significant. So during this project, we learned that properly leveraged electronic medical record data can be a powerful tool of behavioral change and antibiotic stewardship if you have stakeholder buy-in and engagement. There's still a tremendous amount of work to be done to mature and grow this program at CHEO and beyond. You can see the limitations and future directions here. But what struck me is how big an impact we were able to have on antibiotic consumption of children seen in CHEO's eMERGE with a relatively low resource input. Though to improve the sustainability of the program, get it out of Excel spreadsheets into something more robust will be another story for sure. And then shifting gears a little bit to a second sort of area that I was involved with. This project I worked on about two years ago, or over the last 2 years, was to apply evaluation science best practices to stewardship our program at CHEO. Despite evaluation being a Accreditation Canada requirement, rigorous approaches to evaluating stewardship programs remain underutilized in the literature. So I was fortunate to take part in UOttawa's evaluation of health programs micro-credential, and as my longitudinal program, I was able to perform a rigorous evaluation of CHEO's antibiotic stewardship program collaboratively with the stewardship committee or the stewardship program committee. So we designed an implementation outcome evaluation that followed a mixed methods approach. So unfortunately, I don't have time to go into all of the details, and I'll spare you for some of them, but these were our evaluation questions. So in what ways has CHEO's stewardship program successfully helped pediatric physicians and hospital pharmacists optimize antibiotic use? To what extent are pediatric physicians and hospital pharmacists integrating stewardship suggestions from antibiotic stewardship rounds into their practice of antibiotic prescribing? In what ways are pediatric physicians formulating stewardship treatment plan or antibiotic treatments based on their use of the First Line app? And lastly, in what ways has institutional culture for antibiotic stewardship at CHEO changed as a result of implementing our interdisciplinary stewardship program? So circling back to those evaluation science best practices alluded to earlier, the few evaluations that are in the literature of programs that were reported have failed to triangulate findings from multiple sources and have instead really just focused on one data source per evaluation. The triangulation improves the quality and rigor of evaluation. And in stewardship programs, such qualitative and quantitative data would include things like program outputs, like rounds conducted and outcomes of like adoption of suggestions, quantitative surveys, and qualitative interviews. So while each of these types of data are meaningful on their own, in combination, they can generate nuanced and multifaceted insights into stewardship programs and their place in institutional culture. So the data the metadata, I guess, we took into account for the evaluation included a historical survey of pediatric residents and physicians, a more contemporary feedback on our antibiotic report card program, first-line app usage data, antimicrobial use dashboard data, which we'll come to later, and key informant interviews as well. Thanks to all of you, many of you who are listening now, I believe, who participated in this. And so our findings overall were that stewardship rounds at CHEO has made antibiotic stewardship an important part of CHEO's culture. Our antibiotic stewardship program strives to create open dialogue around antibiotic use while respecting prescriber autonomy. Our program has reduced antibiotic use for some specialties using like antibiotic stewardship rounds and innovative persuasive strategies, the report cards namely. Physicians express openness to our suggestions when deemed to be principle-based and credible. Pharmacists who participate in audit and feedback rounds are empowered to suggest optimizations of antibiotic use beyond our rounds, sort of just with the teams that they take part with, work with. Our program stakeholders have really kind of evolved to demand real-time practice data to improve antibiotic use. And then lastly, our app First Line, as one would think, has a reach beyond the current recipients of our stewardship program. So beyond MICU, beyond PICU, surgical specialties, and pediatric medicine. And respondents felt that it was a key resource for physicians in optimizing their use of antibiotics, and they encouraged their trainees to use it as well. So we put forth a set of recommendations after this evaluation, which included strengthening the stewardship program capacity, by engaging pharmacy and infectious diseases experts more, as well as diversifying our educational outreach profile, supporting stewardship program delivery and activities to continue and grow, and then sustaining maintaining and expanding and updating the First Line app. Yeah. So we're working on publishing this in a journal, and if you're interested, more details will be available there, or perhaps internally beforehand. And so as we come to a close, I want to highlight some future directions for our stewardship program, at least as I see it. The first being penicillin allergy delabeling, which is actually an important stewardship tool. So inaccurate penicillin allergies have been compared to a tree planted too close to your house, namely because most penicillin allergies sort of germinate from and are acquired in childhood, and over time, the specific reaction that they had to a medication, truly allergic or not, is forgotten, but the label can persist into adulthood. And perhaps the child has avoided amoxicillin for an otitis media, or another simple infection, or perhaps nothing has happened to them at all, and they just carry this label with them. But at a population level, a disturbing trend emerges. For some unlucky patients, lightning strikes and they suffer avoidable harms. But this risk exists for all patients, who have a penicillin allergy that's inaccurate. And research suggests that most labels are inaccurate. So it leads to prescribing of non-first-line antibiotics, increased mortality risk, increased length of stay, increased hospital cost, as well as association of like more resistant infections. We can avoid this harm by delabeling low-risk patients or patients with low-risk penicillin allergies and educating families on why it's important that we do this. At CHEO, we have a page in first line with eligibility and a simple protocol for delabeling patients in the inpatient setting. And there is an EPIC order set to support this as well. It can be initiated by anyone, but in the future, we hope that the stewardship program can help flag patients for the MRP teams who are quite busy as part of our stewardship rounds, or perhaps roll it out at a hospital level. A separate delabeling program is already well established and has demonstrated feasibility in the emergency department. Another innovative or initiative in development is our CHEO antimicrobial use dashboard. Dashboards allow benchmarking of antibiotic use between and within hospitals and can account for patient case mix and facility level demographic differences. They're often introduced as sort of in bundles and are used to track changes in use rather than as an independent intervention. Dashboards can help build a shared mental model of the problem of excess antibiotic use or excessively broad antibiotic use, or it can highlight really good points of performance among clinicians in different areas. And it also helps build engagement with local QI culture. So here's some screen grabs of CHEO's dashboard. It's currently a work in progress, and you can see how total days of therapy are normalized per 1,000 patient days and how they've changed over time in the hospital and for select provider groups. It also allows slicing by antibiotic type, but I haven't demonstrated this here. Big thanks to those involved in this. Ideally, the dashboard would be publicly facing and stakeholder facing to demonstrate accountability in antibiotic use. It'd be integrated into the electronic medical record to allow for real-time data visualization, which would improve its sustainability and usability and reach. Maintenance and development of the dashboard would be a partnership between the stewardship program and the clinical teams to improve data transparency and credibility. And lastly, it would integrate machine learning to draw attention of stewards to abnormal hospital level patterns in antibiotic use and allow for a more proactive rather than reactive precision antimicrobial stewardship. And the last future direction to highlight would be stewardship in the of discharge patients. So it's estimated, and maybe this is adults and American data, but it's estimated that 1 in 8 patients are discharged with an antibiotic prescription from hospital, but half of them could use some amount of optimization in terms of length, spectrum, route of administration, or discontinuation altogether. And as we move to shorter and shorter total durations of therapy for infections, the number of days prescribed to patients at the time of discharge should be getting smaller, right? But in actuality, discharge prescriptions represent another hidden burden of antibiotic use. Prescribers often perceive discharge as a high-stakes event and sometimes prescribe longer or broader durations of therapies than initially planned leading up to discharge. We've all done it, myself included. And barriers to doing stewardship on discharge prescriptions include, data not being accessible, in the electronic medical record, as is the case with like paper prescriptions, which generally isn't a problem at CHEO. Strategies for doing discharge stewardship have been proposed and validated and have been shown to be effective at reducing use. So bringing it all together, many of you will likely be involved in preparing for CHEO's accreditation, I believe, next year. To date, Accreditation Canada's standards for stewardship programs have been fairly broad and non-prescriptive, as you can see here, pretty low bar, which has allowed for heterogeneity in how they're operationalized. However, Accreditation Canada's partner organization, Health Standards Organization, has come out with much more stringent requirements for stewardship programs to meet. And analogous changes have been made by the American accreditation body, the Joint Commission. This has caused, even like in the States, this has caused even the most robust stewardship programs there to worry about meeting accreditation requirements and how they measure up. And you can see some of the things that are highlighted in red here, which are pretty tall orders for some. And frankly, so should we. But maybe not this coming year with this cycle, but certainly in a future cycle, for sure, these changes will come down the pipeline to us. But with the persistence and innovation and the people I've come to know and love about CHEO, so long as we don't take our eye off the prize, I'm sure we can rise to the challenge. So with that, I'll conclude. I'm so privileged to study such a young and rapidly evolving field where innovative intersectional approaches are being used to meet the needs of stakeholders, new and old. I'm hopeful that the program resourcing at CHEO grows to match the forthcoming aspirational expectations of our accreditation bodies, and that initiatives and services offered by CHEO's stewardship program grow with it. So thank you so much, and I'll take any questions now.
All right, thank you so much, Carsten, for a fantastic presentation, and congratulations to you on all the work that you've presented to us and accomplished throughout your fellowship. And obviously you gave appropriate kudos to all of those who have helped you along the way and mentored you, supervised you, and collaborated with you. It really is a team effort. So congratulations on all of that. So we do have, you've given us a bit of time for questions, which is great. So I'm going to just open it up. If anybody has comments or questions for Carsten, please go ahead, either raise your hand or put a comment or question in the chat. Okay, so I have time then to ask my question, Carsten, while people are thinking about it. So I really appreciate how you have incorporated behavioral science in making these changes. Just giving information is definitely not enough, and how you've shown how that has actually been effective in making change. One thing I'm wondering about is how much you think, for physicians and their prescribing behavior, to actually be mindful about what they're prescribing and to whom. They really have to have a belief that antibiotics are not good in the wrong situations. So how much do you think you've been able to move the needle on really getting physicians to believe that? Much as we're so hesitant now to prescribe CTs if they're not necessary because of the heavy radiation dose, whereas before that was very reassuring to us to be able to get a normal CT and be able to send a patient home. So what's your thought about all that?
Yeah, no, that's a really great question and builds on some important work done by Nisha Thampi, sort of adapting like the stages of change in, like pre-contemplative, contemplative, etc., to physicians in their journey in antibiotic prescribing, as well as Cora Constantinescu out of Calgary. The needle that you're mentioning has, for those who have been recipients of our stewardship program at CHEO, I think already been moved sort of as a group quite far into a sort of a cautious state. Though like individually, there's some variability where exactly within that sort of range the needle is. Although I think for groups that aren't reached currently by our stewardship program, the needle is sort of somewhere a little bit further towards the pre-contemplative stage of things. I feel like over the year, as I've sort of built relationships with providers, people sort of naturally take like trust a bit more in the literature that I share with them. And so I do think it has changed a little bit as well, but definitely a big challenge, and one that takes a lot of time and a lot of face-to-face, chats and sharing of literature and sharing of patient cases.
Great. Okay, thanks, Carsten. There are a few questions in the chat. I know Nicole has her hand up. I just want to comment on the first question about the First Line app. So, is this available to all staff or just physicians? I believe it's available to everyone. I don't know if someone can post a link in there so that anyone who wants that can download it. We promote that very heavily in emergency. So, please use it. It's a great resource for everyone. So we'll go ahead to Nicole, and then we'll come back to the other questions in the chat.
Hi, for some reason, can you hear me?
Yeah, you can hear you. Go ahead.
So one of the issues I wonder about, and I'd like to hear your thoughts on it. And first of all, thank you. It was a real privilege for me to work with Carsten in the last 3 years. So I'm really sad to see him go. But one of the questions I always have is, now that we're promoting, shorter durations for common infections, I wonder if we're lowering the bar, because I've seen people say on the wards, oh, well, we're just going to give them 3 days, or we're just going to give them 5 days. And I've sort of, it's a real issue with me. And I'm just wondering what the balancing measure we need to promote with that, if we're going to say, oh, really, it's short term, short duration, but I worry that we're just giving many people antimicrobials for short durations, and it's our ability to distinguish those who don't need anything versus those who would, benefit from a short course.
Yeah, that's an absolute problem for sure. And one of the problems that, as you know, we've not run into, but haven't been able to address in the prescribing reports so far, is that diagnostic accuracy. Maybe the goal for some patients is 0, but it's hard to know sort of at a high level. And so for emergency department stewardship, I think it needs focused deep dives into specific diseases to make sure that the diagnostic accuracy component, like they did in that sick kids study, is sort of maintained. And then for the inpatient setting, really needs that sort of kind of close attention to the patient by the attending team, as well as the stewardship program when we're reviewing them, rather than sort of glossing over the patients.
Thanks, Carsten.
Yeah.
Okay, so we have only 1 minute left, and there's 2 questions in the chat, and Dr. Batra has his hand up. So I'm going to give it to you, Carsten, to decide. Do you want what's behind door number 3 with Dr. Batra's hand? Do you want to talk about AI, ChatGPT for where the future is, or do you want to talk about the whole issue about restoring good bacteria in the gut in response to antimicrobial use?
I think I'll take the comment from Dr. Gilchrist in the chat, just because I think many people will be interested in that. So the question is on how to recover good bacteria after antibiotic therapy is complete or has been damaged by antibiotic therapy. So this is an interesting and evolving area of research in pediatrics. There's many limitations in probiotics, symbiotics, and sort of chaperone therapies, giving small molecules that we believe are produced by the good bacteria that benefit the body. I think really the focus has to be on prevention of harm rather than sort of coming and trying to recover the damage at the end. But that being said, there is some emerging evidence for fecal microbiota transplants, in immunocompromised patients who've sort of had their gut microbiome ravaged by recurrent and prolonged broad spectrum therapies. And that has been shown to help repopulate their microbiome, as well as sometimes help them shed resistant pathogens. But that being said, again, we should be focusing on prevention, as FMT is still experimental in our pediatric population.
Wow. Very helpful and concise response to that question. Very informative. Thank you, Carsten. And thank you to Anne for posting the link for the First Line app. And definitely agree with your comment, Anne, that big kudos to Nicole and Carsten and the whole team on all the advances you've made in the antimicrobial stewardship program. We really are a leader here at CHEO, thanks to all of your efforts. So thank you very much. And with that, we will conclude our rounds for this morning. Thank you again to all. Have a wonderful day.